Welcome to Conversations with Dr. Arasi Maran. In this episode, we're going to be talking about the surgical options for obesity. I have with me Dr. Rana Pullatt. Dr. Rana, you recently won the award for clinical excellence from the American Society of Metabolic and Bariatric Surgery. Obviously, that's a great honor. So can you kind of take us through what are the available surgical options for the treatment of obesity?
Yeah, I think, thank you again for having me on this podcast episode. I would like to start off with endoscopic management and then advance towards surgical management. The endoscopic management starts off with what we used to use called balloons, and it's still being used. Some of them are swallowable balloons, some of them are endoscopically installed balloons. These act as space-occupying lesions in your stomach and work purely on mainly restricting the amount of food.
So let me visualize it. So you take a balloon and it's just placed inside the stomach, and therefore it reduces the size of the stomach?
It reduces the area of the stomach that can be filled with food. So you basically have a space-occupying lesion in the stomach. So endoscopically you put it in and then by some means inflate it. And some of them are self-inflatable and some of them are endoscopically inflated. You keep that in for about 6 months, depending on patient tolerance, and you take it out and you've got some weight loss. The problem, as you can see, is there's no real lasting hormonal effect for the balloon, and you end up having weight loss as long as you keep it in, and then you end up gaining the weight back on. So it's not a very durable form of weight loss. So that's the problem with just having an endoscopic.
It's almost similar to it's almost like a cosmetic procedure.
I wouldn't say cosmetic, but I think it's not a very durable solution to obesity, because you know that obesity is a lifelong disease. So just having something done for 6 months is really not going to last. There were some stents that were designed that try to simulate bariatric surgery, like you would put a stent which would extend from just the exit of the stomach, which is called the pylorus, all the way into your intestine, and that would prevent the food from contacting the first portion of the intestine. But that didn't work because of issues of hepatic abscesses that were forming because of the mechanism by which it latched on. And there's also a risk of migration of that. So those didn't really take off. There's a newer procedure called duodenal mucosal resurfacing that is being done where the duodenal mucosa is denuded by heat therapy and thereby causing some alterations in the way in which you absorb food. There's also a really strange device for you that it might seem very strange, but it's called...
I know where you're going with this.
It's almost like a tube that is installed into your stomach, and you basically, once you eat your meal, you pump out the food.
Isn't that what binge eating disorder is?
No, it's basically like some sort of surgical bulimia. Instead of throwing up and causing a lot of damage to your esophagus and gastroesophageal junction, basically you can eat your lunch or dinner and then go to the restroom and pump out maybe 30 or 40% of what you've eaten, thereby getting the satiation of the meal. Having said that, all of these have not really taken off in a huge way.
Absolutely, I can understand why though.
The more exciting thing that people are doing now in large numbers and have some amount of long-term results which are promising are the endoscopic sleeve gastroplasty, where the stomach is stitched from the inside. That coupled with medications may be a good approach, because especially you come in, you don't undergo surgery and you just undergo endoscopic sleeve gastroplasty. Now that's not for all forms of obesity, that's not for the super obese, that's not for people beyond a particular BMI. So it's good for moderate obesity. I think it's a good approach. It is not very durable in that you may have to redo that procedure every year, or depending on how well opposed the stomach is. The stomach's not very easy to.
Is it easily revisable when you go back for revision?
So that is the attraction of that procedure, that you can go endoscopically and snip it. But there have been case reports of obviously issues with the stomach scarring down and it not being as easy to reverse as it's advertised. So that's the more exciting endoscopic form of therapy that's out there. For the surgical treatment of obesity, this was all started in the 1950s and 60s. The father of bariatric surgery was Ed Mason, who popularized bariatric surgery. At that time, it was a fringe specialty, almost done in secrecy. The surgeons were, the bariatric people who were doing bariatric surgery were considered like the bottom of the surgical hierarchy. They were not considered real surgeons. It was thought to be experimental, and people looked at obesity as a
goes back to the moral shaming of
thing. Even
obesity.
the treatment, even the people who were indulged in treating of it were basically shamed, and the societies were almost like very, very small. And but Dr. Ed Mason, he was what you'd call the father of bariatric surgery for the world, and he popularized certain procedures that were like the Mason bypass. So there's been a huge evolution of procedures. Right now, the International Federation of Society of Obesity and the American Society of Metabolic and Bariatric Surgery have certain what we call approved list of surgeries. There have been certain surgeries like vertical banded gastroplasty, which have fallen out of favor, so I'll not concentrate on those. But the approved ones, by and large, which the majority of the world in bariatric surgery use, are the laparoscopic gastric band, the One-Anastomosis gastric bypass, the Roux-en-Y gastric bypass, the sleeve gastrectomy, the laparoscopic single anastomosis duodenal switch, and the laparoscopic double anastomosis duodenal switch.
This is like a long list of procedures. How do you decide which one to go?
Yeah, so let's start with the simplest of procedures, which is the laparoscopic gastric band. It basically is almost like a band that we put around the upper portion of the stomach, just below the gastroesophageal junction, and it works. It has an inflatable balloon contained within it, and it has a port. And the port is accessed, it's put in a subcutaneous area in the abdomen, and its port is accessed, and you can push in saline into that port. And when there's a certain amount of saline that's in there, usually about 1 or 2 cc's, the patient feels full when they eat. And the advantage of that is that you can adjust how
based on the weight loss.
Yeah, and how much you need. So it was initially one of the most common procedures done. However, it's fallen out of favor because any kind of material that we've put around the stomach and gastroesophageal junction have always eroded. So there are problems of erosion, and there's not really a hormonal mechanism. It's purely
a mechanical
purely
restriction.
a restrictive thing, so it's not very well tolerated. Over time, there are problems of erosion. There are times problems of slippage of the gastric band, which can be an emergency. So it has now fallen out of favor from being one of the most commonly done procedures. It's done in very, very selected patients in very few centers around the world. The single most common procedure that is done world over is what's called a sleeve gastrectomy. And the sleeve gastrectomy is basically creating a small stomach by removing the expandable portion of the stomach. It's an expandable organ. Yeah. So you can eat 2 or 3 liters of food, and the stomach can accommodate.
You're not going to feel good after that, but you can.
But the stomach can accommodate it. And usually what happens is that the fundus, which is the most expandable portion of the stomach, fills up with food, and once you have that, you get satiety, because ghrelin is an orexinogenic hormone which is secreted by the fundus, and when the fundus is full, ghrelin production stops, and thereby you have satiety, and that's how you stop eating. And it can happen at different thresholds for different people. Now, in a sleeve gastrectomy, what you do is you remove and size the stomach to about, roughly, you basically use what we call a bougie or a sizing device.
Instrument.
And we place it along the lesser curvature of the stomach, and then we excise the portion of the stomach that is in excess of it. So you end up with a narrow banana-shaped stomach that can only accommodate certain amount of food. They get really full very quickly. And the advantage of it is you're not rerouting the intestine. So there's no
anastomosis happening.
Yeah, no anastomosis. So the risk of obstructions and internal hernias are almost non-existent.
But the thing is, we started this conversation by you telling me how stomach is an expandable organ. So what are the chances the stomach just does not expand again over time?
So in majority of patients, it doesn't, because you are basically, the stomach that you're leaving is based on the lesser curvature. And the lesser curvature is more muscular and less distensible. Having said that, yes, over time, sleeves can dilate and become larger and lose their effectiveness. But it's like saying that, but it is the single most commonly done procedure. The leak rate is very, very low, less than 1%. The advantage of bariatric surgery right now is the mortality rate of bariatric surgery is equivalent to that of a gallbladder, less than that of a gallbladder, or much lesser than a hip replacement. So when people get their gallbladders and hip replaced without thinking twice, people always look at bariatric surgery as something that's, oh my God, it's like dangerous. It is not. It is the safest it's ever been, because stapler technology has improved so much that really it's become pretty
I think
safe.
it comes back to the same shame part of it, right? If people think of it as a shortcut, that they're not doing it the right way, they're taking it as a shortcut.
So it would be like saying that you've got cancer, but I'm not going to treat you because you should just do some natural remedies. Or you got diabetes, I'm not going to give you insulin. I'm not going to give you medications. So surgery is a valid form of treatment of obesity. So it's not, because you can do self-control. Self-control works when you're awake. Physiology works 24 hours a day, even when you're asleep. So you cannot fight physiology. And medications and surgery effectively break that cycle of the metabolic issues and the metabolic derangements that happen in your body, and give you a fighting chance of being able to overcome obesity. So the sleeve is extremely safe. It's the most common procedure done. It's a very quick procedure. Most patients stay overnight and go home the next day. It's all done laparoscopically with small incisions, or some centers do it robotically. It's a very, very, very safe procedure, and that would be the procedure that lots of people do. But having said that, there are certain contraindications. If somebody's got really bad reflux disease, acid reflux disease, on medications, and have changes which are called Barrett's esophagus, or they have severe esophagitis on their endoscopy, then the sleeve may not be the best procedure for them.
Now, how much weight loss do you expect? I mean, if I have a 200 kg or a 300 kg patient, how much weight loss can they expect?
So it's very, very dependent on individual metabolism, and it's really hard to predict that. And you're usually looking at about 20% of total body weight loss with these procedures. In some people it can be more, it can be 25 to 30%. In some people it can be less.
Now let me ask you, we talked about Mounjaro causing almost 20 to 30% weight loss. So do you see, do you expect a drop in the number of gastric sleeves to happen?
So I think, you can look at it in both ways. You can look at it as, some people are going to go the medication route. Having bariatric surgery is like hitting obesity with a sledgehammer. So it works very, very, very quickly, and it works very dramatically. I think it's going to be more combination therapy than one replacing another. And right now we don't know who really the medications work well, who surgery works well.
It's such a brand new entry.
So there's going to be randomized control trials. basically looking at effectiveness of surgery versus medications. That's the only way we can tell. But what medications have done is dramatically increase the awareness of obesity as a disease.
Absolutely.
Because till this, obesity was considered a moral failing and a disease of volition. People have finally come to realize that obesity is a disease and it needs treatment.
Fantastic.
So the next aspect of surgery is what was considered the gold standard of bariatric surgery for a long time, which is called a gastric bypass, where we cut the stomach and make a small pouch and then connect the bowel directly to it, thereby reducing the amount of food that goes into the gastric pouch, and then
you're bypassing the small intestine.
Bypassing some of the small intestine, thereby causing some of the hormonal changes we talked about, the GLP-1, and making your body more insulin sensitive. And that's how gastric bypass works. But the negative side effects of it is there's a small percentage of people who may get obstructions or internal hernias.
The general surgical complications from anastomosis.
Anastomosis and internal hernias.
Okay.
But the weight loss is pretty dramatic. It's both sleeves and gastric bypasses are pretty equivalent weight losses at a 5-year to 10-year level, maybe a little bit more in a gastric bypass. But it's an excellent treatment for acid reflux. So people with bad acid reflux or Barrett's esophagus or
who can't get gastric
esophagitis end up with a gastric bypass because it treats both, because the acid-producing area of the stomach is the body of the stomach, which is now disconnected from the gastroesophageal junction, thereby preventing acid from bathing their GE junction.
Now, I've definitely heard you talk about duodenal switch.
Yeah, before that, I want to mention the other surgery that is very popular or becoming more popular, and especially popular in India, is the One-Anastomosis gastric bypass, which is a small, narrow gastric tube and a loop anastomosis done at the end of the gastric tube. The proponents of One-Anastomosis gastric bypass have shown excellent weight loss, but there's still some issues of bile reflux or not, but it seems like in some of the studies it doesn't seem to be that much of an issue. However, long-term studies are still going on comparing the efficacies of these. The most effective surgery for obesity is what we call the single anastomosis duodenal switch or the double anastomosis duodenal switch. There are two variants of it. The single anastomosis duodenal switch, where we basically create a sleeve gastrectomy by narrowing the stomach, taking out that greater portion of the stomach, and then we dissect past the pylorus into the first portion of the duodenum, transect the duodenum, and then bring a loop of ileum, which is about 300 centimeters from the ileocolic junction. The other variant of it is what is called a double anastomosis duodenal switch, which we use in the extremely super obese, but the risk of internal hernia and obstruction is there in those. So these days, the single anastomosis duodenal switch has become a very popular way of treating the super obese patients, usually with a BMI greater than 50 or in bad diabetics, because of the maintenance of the pylorus, unlike the gastric bypass where the food goes directly into the jejunum and causes insulin and glucose spikes. Here there's a steady state glucose maintained by maintaining the pylorus. And it takes away the problem of anastomotic strictures as well as ulcers, because you maintain the pylorus and you're doing the anastomosis from the duodenum to the ileum, which the duodenum is protected by Brunner's gland.
Is this popularly done?
So it's increasing in popularity in the United States. Some of us have been doing it more.
It sounds like a very technically advanced procedure.
Yes, but with the advent of the robot, this has become a lot more accessible, and a lot of young surgeons now, as well as experienced surgeons, are coming to centers like mine, and there are a few other centers that do it really well, get proctored and trained, and being able to successfully reproduce it.
What does the future look like?
So I think the future of obesity medicine and surgery is very, very exciting. There's going to be, we're at the very, very beginning of it. We don't even know what surgery works best for what person, what drug works best for. Each of us have a personal obesity threshold, so exploration into that, figuring out even before treating the patient what probably works well based on their genetic.
Absolutely. I would love to know my personal obesity threshold.
Based on their genetic predisposition towards obesity, figuring out what really works would be the next step.
Fantastic. Now, genetic therapies, I mean, is there blood tests, like genetic, are there anything?
So as we discussed earlier about pediatric obesity,
Yes.
there are certain kind of diseases that do have a genetic target, like leptin deficiency, melanocortin, POMS. There's different syndromic obesities that are being treated now with therapy that is directed towards that, but we have not yet gotten into the genetic manipulation and those kind of treatment.
Fantastic. Thank you, Dr. Pullatt. I think we've had a very interesting series here. We started with the evolution of obesity. We talked about the different myths and doubts surrounding why we are obese. We talked about childhood obesity, and we also talked about lifestyle changes, invasive therapy, medication therapy, surgical options, and the future prospects too. I hope this series has been useful in reducing the moral shaming associated with obesity. Obesity is a lifelong chronic disease, and like any other disease, it needs a multidisciplinary approach. I hope with this series I've increased the awareness about obesity, and I also hope it provides the adequate information people with obesity need for their treatment. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.